Hello, I'm Caitlin Jorgensen, and this is my high deductible health plans and rising costs in healthcare presentation for HCM 6040 Health Policy and Ethics. Today I will be discussing the expansion of high deductible health plans, or HDHPs, within the broader U.S. health insurance system. Specifically, I will examine how increasing deductibles affect access to care, healthcare utilization, and financial protection. While these plans are designed to control costs, the evidence suggests they shift financial risks to patients with uneven effects across populations. Rising healthcare costs in the U.S. Healthcare costs in the United States have risen steadily for decades, consistently outpacing wage growth and general inflation. This has created financial strain for employers, government programs, and households. In response, policymakers and insurers have pursued strategies to slow cost growth while maintaining access to care. One of the most significant tools used in this effort has been insurance benefit design. Insurance benefit design as a policy tool. Benefit design refers to how insurance plans structure deductibles, copayments, and coinsurance. Over time, there's been a shift toward increased cost sharing, meaning patients pay more out of pocket before insurance coverage begins. The expansion of consumer-directed health plans reflects the belief that exposing consumers to greater costs will encourage more responsible healthcare decisions. Now, there's public and private health insurance. Public and private insurance models differ significantly. Public programs such as Medicare and Medicaid are based on social insurance principles, emphasizing broad access and risk pooling. Private insurance, primarily employer-sponsored, increasingly relies on market-based approaches that emphasize consumer choice and financial responsibility. These structural differences shape how risk is distributed and how care is utilized. Public insurance characteristics. Now, public insurance programs determine eligibility based on age, disability, or income. Benefits and cost sharing are defined by federal or state policy, and these programs are generally known for having lower deductibles and more predictable cost sharing, with a strong emphasis on financial protection for vulnerable populations. A private insurance evolution. Historically, private insurance plans used moderate deductibles with copayments and coinsurance. However, rising healthcare costs led employers to adopt higher deductibles to control premiums. The assumption was that the increased cost sharing would discourage unnecessary utilization and reduce overall spending. And therefore, we have the emergence of HDHPs, high deductible health plans. They've grown rapidly. These plans are often paired with health savings accounts, also known as HSAs, or flexible spending accounts, which are known as FSAs. Together, these arrangements increase upfront financial responsibility while offering tax advantages to offset some of the costs. Policy rationale for HDHPs is grounded in consumer choice theory. The idea is that when patients spend more of their own money, they will compare prices. They'll question the necessity of services and seek higher value care. In theory, this should create a more efficient healthcare system. The Medicare Modernization Act of 2003 established the legal foundation for HSAs and formalized HDHP eligibility criteria. The Internal Revenue Service, or the IRS, defines the minimum deductible thresholds and maximum out-of-pocket limits. The legislation significantly expanded consumer-directed health plan adoption. Access to care under HDHPs. The research by Davis and his colleagues in a 2005 study found that individuals enrolled in HDHPs are more likely to delay or forego care due to cost concerns, even though they are insured. This includes routine physician visits and follow-up care, which patients may perceive as discretionary when faced with high upfront costs. Preventive and prescription care. Although many HDHPs exempt preventative services from deductibles, confusion about coverage and fear of unexpected bills still deter some patients from seeking preventative care. Prescription drug use also declines under HDHP enrollment, and reports of skipped doses or delayed refills due to cost pressures. The impact on chronic conditions is especially concerning. Studies show that these patients are more likely to postpone recommended tests and follow-up visits. Over time, this can lead to worsening health outcomes. These effects disproportionately burden low-income individuals and those with ongoing medical needs. One of the core purposes of insurance is financial protection. However, evidence suggests HDHP enrollees experience increased medical debt despite having coverage. High deductibles constrain household finances and raise important equity concerns. A study by Waters and colleagues in 2011 used a difference in differences approach to analyze HDHP enrollment. They found reductions in emergency department use, suggesting that higher cost sharing may deter some high-cost services. However, outpatient care changes were mixed, and prescription drug use declined. Overall, the evidence suggests that spending reductions under HDHPs reflect cost shifting rather than true efficiency gains. Patients reduce utilization because they bear more financial risk, not necessarily because care is more appropriately targeted. Economic perspective on HSAs. Gardner and Showalter's economic analysis shows that HSAs tend to benefit healthier and higher income individuals. These individuals can afford to contribute to savings accounts and take advantage of tax benefits, allowing HSAs to function as both insurance and investment vehicles. HSAs also will follow you from year to year, whereas your FSA does have basically an expiration date and you will lose those funds. A key concern is adverse selection. Healthier individuals are more likely to enroll in high deductible health plans, leaving sicker individuals in traditional plans. This can destabilize insurance markets and increase premiums for those who remain in more comprehensive coverage. The winners and the losers. Employers and insurers benefit from lower premiums and reduced claims exposure. Healthy, higher income individuals benefit from tax advantages. In contrast, low income individuals and those with chronic conditions bear greater financial risk and reduce access to care. Policy alternatives. Potential alternatives include income adjusted deductibles, exemptions for chronic disease management, increased employer or public contributions to HSAs, and improved price transparency tools. These approaches could preserve cost control goals while improving equity and access. In conclusion, while HDHPs align with market-oriented health policy goals, the evidence suggests they reduce access and financial protection for vulnerable populations. They have that ongoing challenge of preserving equity and access amongst all populations. Thank you.